So good morning, and I'm really happy to be here to talk about a topic I think is really important, financial hardship in cancer survivors in the United States especially, but I will be focusing on the US, but it's increasingly a problem in other countries as well. So as you can see, here's my name without the K, and I'm very easy to find if you have any questions. Yabroff at cancer.org. So I want to start by giving you some background. What is the big picture with cancer survivorship in the US? Currently, there's about 15.5 million cancer survivors who are alive. Those are individuals who are diagnosed with cancer and are currently alive with cancer. For most cancers, incidence rates increase with age, and the prevalence of cancer survivorship is also highest in the elderly. We have a number of recent trends that are important in thinking about cancer survivorship. The incidence rates are mostly declining, and when I say rates, I mean per 100,000, not the actual number of newly diagnosed cancer patients. And then also survival following diagnosis is improving, and that reflects differences or improvements in early diagnosis and better cancer treatment. But despite those two trends, and in part because of the increased survivorship, and also with aging and growing of the US population, when we hear about the baby boomers, people who are getting older, there's a much larger population of elderly with higher risk of cancer. So overall, we expect the population of cancer survivors to increase quite a bit, to about 18 million by 2020. And the 15.5 is for this 2017, so it's recent data. So we expect a lot more cancer survivors in the future. In this slide, I'm going to share some work we did to estimate national spending on cancer. This is for a number of the most common cancer sites, but overall it's about $125 billion. This is in 2010. If you look at the top of the graph, you'll see that the greatest spending is for the most common cancers: breast, colorectal, lymphoma, lung, prostate. In this next slide I'm sharing with you, the red bars reflect the change in national spending on cancer care based only on those population changes I mentioned earlier. So the aging and growing of the US population means more people diagnosed with cancer and more people surviving. So if you look at the bottom of the slide, it's about $158 billion. That is a 26% increase compared to what we saw in 2010. And that's just based on population changes, nothing else. And of course, we know there are lots of changes in cancer care especially. This next slide shows dramatic increases in the monthly price of cancer drug at FDA approval. Some of the data are a little old, but the trend is what we are continuing to see. If you look in the early 1960s, 70s, monthly price of cancer drugs was in the under $40 per month range. And then we move into the early 2000s, we start seeing many more drugs in the $15,000 a month range, and that continues to go up. And most recently, we now have a drug that was approved for more than $400,000 for a single treatment. From the perspective of patients, this is really important. It's because patients do pay a component of that total price. It's also important for the country as a whole in thinking about how we spend money. Many of these drugs, the differences in what patients pay is based on whether these are oral drugs or whether they're infusion drugs. And many of the oral drugs, for the cancer drugs especially, they're on what's called a specialty tier. And so that means the patient pays, rather than a flat rate or a flat number, they pay a coinsurance rate, which is a percentage of the total. And so if we think of a drug that might be $100,000 a year, if patients are paying 30% of that out of pocket, and that's a pretty common coinsurance rate for specialty drugs, that's $30,000 a year, just for the drug, nothing else. And then if you think about those much more expensive drugs that we're increasingly seeing, that amount is more. And just to put that into perspective, median household income is about $56,000 a year. So when you think about out-of-pocket expenses for a single drug of in excess of $30,000, and that's for the less expensive drugs that we're seeing currently. Okay, so there are also some trends that are affecting financial hardship I want to talk about. So I just told you about the increasing cost of cancer, treatment for cancer and other conditions. I showed you drugs. That doesn't include advanced imaging. It doesn't include supportive agents. It doesn't include the fact that we have broad changes in treatment patterns. So more patients are getting treatment. The types of treatment they're getting, they're more likely to get treatment in combination, so multiple treatments, and they're also getting treatment for longer. So this is, the fact that many patients are getting treatment for longer in many cases is good news, but it's also expensive. We also have broader trends in the United States, especially those related to health insurance coverage. And this has been a topic of hot debate recently. But what we're seeing now is increased prevalence of high deductible health insurance plans. So what this means is that insurance coverage doesn't actually start until after patients meet a minimum deductible. So we went from something like 12, 13% of private insurance being with high deductible health plans, and currently we're well over 40%. So this is a pretty big change in a relatively small period of time. We're also seeing more patient cost sharing, and that's, of course, only among the insured. Patients without health insurance are responsible for the entire bill themselves. And I also want to comment a little bit about what we're seeing in terms of what I'm calling underinsurance. This is patients, or this is individuals who may not have complete coverage. So most recently, we're seeing an increase in what's called short-term plans. And these plans are not covered by a lot of the legal protections contained in the Affordable Care Act. The majority of these plans don't even cover prescription drugs at all. So increasingly we're seeing greater risk of patients being uninsured, and then also more challenges to coverage. Within the past year, we've seen repeal of the individual mandate. We are also seeing challenges to Medicaid programs where there are work requirements, which make it more difficult for patients to remain enrolled in Medicaid. So those are some of the main things that we're seeing with underinsurance and uninsurance, but we're starting to see more upticks in uninsured after many years of declines. So when we layer what's happening with cancer survivorship on top of these broader national trends, we've known historically that cancer survivors can experience lasting effects of disease and its treatment, and they are more likely to have risk for additional cancers, multiple risk for additional chronic conditions, and multiple chronic conditions. They have greater healthcare spending. And importantly, they're more likely to have limitations in the amount or kind of work. And the reason this is so important is not only reduced income from inability or limitations in ability to work, but also in the US for the population under age 65, our health insurance coverage is predominantly through employment. So individuals who may not be able to work may also lose health insurance coverage for themselves and also their families. So now I've given you a big picture. I'm going to talk a little bit more about patient experiences with financial hardship. And I'm going to read a couple quotes. My colleagues and I did a study where we asked cancer survivors, and these are mostly long-term cancer survivors, so not newly diagnosed patients. We asked them about their experiences with financial hardship. And I really want to read these quotes because they are very compelling, and also because one of the speakers today was not able to make it, who is part of the Poxy group. So this first quote says, "I am still paying for debt accrued from co-payments or hospital bills not covered by my insurance. and paying credit card debt that was accrued during my time out of work. The next quote, we had to let our home go back to the bank. After 20 years of home ownership, we had to file for bankruptcy. The next quote, I paid most of my costs out of pocket. My savings were wiped out. Now I struggle and I'm ashamed by my lack of funds. I don't know if I'll ever recover financially. It's a considerable stress. And then finally, I stayed with a company that provides excellent health benefits rather than seeking a higher paying job where the benefits may not be as good. So I've described to you a lot of different components of financial hardship: high cost, impacts on housing, impacts on employment, and impacts on stress. In this next slide, I want to share some data from colleagues in Washington State. It's a really interesting study where they link data from cancer registry to bankruptcy claims. And to orient you to the slide, the red line represents cancer patients. And this is many years after diagnosis, not just newly diagnosed. And the blue line represents matched controls. So these are individuals who are very similar to the cancer patients, except for the fact that they had cancer. And what you can see is in every single year, cancer patients have higher risk of bankruptcy compared to those without a cancer history. There's a little blip that reflects a policy change, but in every single year, there's higher risk of bankruptcy for cancer survivors. So after they completed that study, they then looked only in the group with a cancer history and did some follow-up to look at risk of death. So the question is, are people who file, or cancer survivors who file for bankruptcy, are they at higher risk of death? And unfortunately, the answer was yes. So they found that filing for bankruptcy was associated with a much higher risk of death, even when comparing for a lot of different characteristics. So things that we know are associated with prognosis, survival, stage of disease at diagnosis, treatment, age, other area level characteristics. And these findings were really robust in sensitivity analysis. But it weren't really clear what this mechanism might be. Why would people who file for bankruptcy be at greater risk of mortality? And some of the hypothesized mechanisms include lower quality of life and overall well-being, things like potentially having food and housing insecurity, increased stress or distress, and decreased treatment adherence or access to care. And in many cases, we're interested not only in access to cancer treatment, but also access to other treatment. As I mentioned earlier, cancer survivors are at higher risk of other conditions. So it's not only the cancer care there may be decreased access to. So about the same time this work was coming together, my colleagues and I were thinking of how to conceptualize financial hardship, and we developed this framework based in part on the health disparities literature, where we defined 3 large domains, the first being material conditions, things like high out-of-pocket spending, psychological response, that would be like a stress response to the high out-of-pocket spending, and then also coping behaviors, changing or being less likely to adhere to medication because of cost. The main thing I want to point out about this figure is the idea that these domains are distinct, but there's also room for overlap within those domains. So when we applied this framework in thinking about financial hardship in national data that was collected as part of the Medical Expenditure Panel Survey, Experiences with Cancer, we asked long-term cancer survivors mainly what their experiences were, their financial experiences were. About 7% had to borrow money or go into debt. 2% had filed for bankruptcy. And I should mention that all of these questions were specific to as a result of your cancer, not broadly, because many, many Americans also face financial challenges, but these questions were very specific to cancer. 12% were unable to cover the share of their medical costs. and 9% made other financial sacrifices. So if we take all of those together, about 20% of cancer survivors report having financial hardship, material financial hardship, and 23% report psychological financial hardship. That's worry about their financial situation. In this next slide, I'm using the same data, but you'll notice that it's stratified by age. So we're looking in the top bar at those who are 65 and over, and in the bottom bar, those who are 18 to 64. And we made that separation in part because of age eligibility for the Medicare program at age 65, and also differences in employment in those two age groups. So I'm going to start by pointing out that the blue is not having any hardship, yellow is psychological, gray is material, and then the red is both. So remember that figure I showed you with the domains where there's some are distinct and some overlap. That's actually what we're seeing here in this figure. Importantly, we see a really big difference by age group. So about 40% of cancer survivors who are age 18 to 64 report some type of hardship, either material or psychological, compared to about 20% of those age 65 and over. And then when we look a little bit in more detail, we also see that health insurance, not surprisingly, is strongly associated with financial hardship. You see almost 50% of those with public insurance or who are uninsured under age 65 report material financial hardship. The main thing I want to point out, though, is what we see when we look at those with any private health insurance. It's not, in that age group, it doesn't eliminate risk of financial hardship. We still see about 24% of cancer survivors with private health insurance, age 18 to 64, who reports material hardship. It's much lower for the older population, closer to about 12%. And then there's much less variation by type of health insurance in the older population. And when we looked at this for psychological hardship, it's very similar. So in this next slide, I'm sharing results from another study where we looked in detail among cancer survivors who said they incurred debt, how much did they actually incur? So for the most part, less than $10,000. That's the blue color in this pie graph, 44.8%. Importantly, though, about 13% report more than $50,000 in debt. And remember, median household income, about $56,000. So, I mean, we were talking about some significant hardship for at least a pretty large subsection of cancer survivors. This next slide shows you what cancer survivors report spending money on. So this is for those who reported borrowing money or going into debt. Not surprisingly, almost 100% report for medical expenses. But they're also spending money, 60% are spending money for transportation and lodging and childcare and home and respite care. So many cancer patients and their families need to travel to receive care, and that's reflected in this graph. So in this next slide, I'm showing you a little bit about what we're calling behavioral financial hardship. This is delaying filling a prescription, taking less medication, or skipping medication doses. To orient you to the slide, the blue is individuals without a cancer history, the red is those who are recently diagnosed, and the green is those who were previously diagnosed. The main point I want to make is those green and red lines, those who were previously diagnosed and recently diagnosed, still show statistically greater percentages of delaying filling a prescription, taking less medication, or skipping medication doses. So the effects of financial hardship are long-lasting. So I don't have time to share all of the research related to financial hardship, but I do want to quickly summarize some other patient characteristics that are associated with greater risk. So younger age, being female, minority race and/or ethnicity, lower household income, being unemployed, and those who changed employment because of their cancer, uninsured or underinsured, cancer type. We do see that for cancers that tend to have more intensive treatment, risk of financial hardship is greater, and then more recent diagnosis and/or treatment. So I want to give a quick summary of what I've shared with you so far. We do see different aspects of financial hardship: material, psychological, and behavioral. We also see that it's relatively common. So about 40% of the population 18 to 64 report some form of financial hardship. We saw that there's more out-of-pocket spending is for more than just medical care. It also includes things like transportation and lodging. And then when I showed you that summary slide of patient factors, the evidence is really very consistent that we do see higher risk of financial hardship in populations that traditionally have more problems with access to care. And so one comment I really want to highlight is that there is a potential for widening disparities in outcomes for cancer survivors based on financial hardship and also based on a number of the trends I talked about earlier. So this next slide I'm sharing with you, I like to call it the onion because it's sort of like an onion. So in the center of the slide, you have patients and family, and that's where I've shared most of the data so far, and that's where we have the most information about about financial hardship, patients and family. But that is surrounded by the provider and care team. So things like what sorts of discussions are happening about the cost of care and risk of financial hardship. Those are the sorts of things we might be interested in at that level. And then the next level is health system and or practice setting. What resources are available in the community, and how does the health system structured, and what is the effect on hardship? And then finally at the state and national policy environment. And you heard me talk a little earlier about changes in health insurance, and this is certainly a very important area when thinking about financial hardship. So I want to end with a couple of questions, and then of course I'm hoping to have a robust discussion. So when we're thinking about these factors at multiple levels, at the patient and family level, what is financial health literacy? How do you measure it? How do you improve it? Is it associated with changes or treatment decisions? When we think at the provider and team level, who is the best member of the team to discuss financial hardship with patients and their families? And what is effective financial navigation? I was really pleased to see that there's a breakout later today on financial navigation, really important topic. From the practice and health system perspective, how can documenting and addressing financial hardship play a role in quality improvement? Can we use electronic health records that include things like prompts and reminders? Can we use those to encourage conversations about hardship? And can we also measure the extent to which those are happening? I think, from my perspective and thinking about quality improvement, measuring what's happening is the first step. And from the policy level, can health insurance coverage and benefit design be structured to minimize risk of hardship? So I will move back to my previous slide. Looks like I didn't include it. Increasingly, I've been adding a layer for employers because I think they play a very important role in thinking about hardship. Employers are the ones that typically offer insurance coverage for their employees. So if they're choosing to offer a high deductible health plan, that is a policy that employers are implementing that affects risk of financial hardship. And then do they offer paid sick leave? For many patients, choosing between an expensive treatment and knowing that they don't have paid sick leave can make a choice. Can make that choice clear in terms of adherence, and it can also have adverse effects on their health outcomes. So anyway, as we are thinking about how to address financial hardship and develop interventions to improve it, thinking about all of these levels shown in this figure, I think it's an important way to start, but also a way to think about those different policy levers that we might use at different levels. So with that, I'd like to thank you, and I'm looking forward to your questions. Yes?
Hi, Mark Cohen from Blue Cross. One onion I didn't see also were the drug companies. And, you know, one thing you see quite a bit nowadays is if you have financial hardship, please give us a call and we'll help you. And I'm wondering, how does that mechanism work, and how do they afford that? Is that passed down some way, somehow? And what's their criteria that they use to like limit that eligibility?
That's a really fantastic question and point. It's kind of difficult to answer in the next couple hours. I mean, it's a big issue, and I think what you're referring to is coupons for specific drugs and also patient assistance programs. And so those programs tend to offer assistance for particular drugs. They also offer for what's called pharmaceutical benefits managers. They do contracting around specific drugs, classes of drugs. It can be pretty complicated, and you do start to see the coupons as drugs are coming off patent. This is not an area it's an area I'm very interested in. I don't have a lot of detailed knowledge, but I agree with you that is an important point to consider, but it's really heterogeneous. So some drug companies are offering financial assistance for a limited number of patients, and so for some of these programs, they fill up by the end of the year, or they fill up early in the year, I'm sorry. And in some cases, it can distort the price of drugs. It can also distort what drugs are contained on different formularies. So, and without getting into too much detail, many insurers have formularies of drugs that are preferred or covered. And so these agreements that pharmaceutical companies have with insurance carriers and pharmaceutical benefits managers can influence which of the drugs are on the formulary for patients. So it's really complicated, but it's also really important in thinking about financial hardship. Thank you.
This is Dr. Katato from Flint. One question not included here is a lot of patients seek alternative or complementary therapy and pay out of pocket for that, and that may be contributing to their financial toxicity, and that sometimes can be very expensive.
Mm-hmm. That's a really good point. We don't always have good information about the types of complementary and alternative medicines patients are taking, but I agree with you that they are probably paying for most of this out of pocket.
Hi, Tom from Carmanos. So you stated the first step is measurement and classifying the type of interactions and maybe the quality of the interactions. And so I'm a physician, and I can tell you the quality of my interactions are poor. The number of the interactions I have are bad or few. And it's just a very complex system for me to understand. Has the patient met their deductible? Do they have a high deductible health plan? You know, where am I at within surgery or chemo or radiation? Are we going to be able to get them drug assistance or not? I mean, like, this is incredibly complex. Why are we not starting developing price transparency and tools to help physicians understand what things cost rather than quantifying the interactions?
Okay, so I agree with both of your points that it is incredibly complicated. And I will also say I'm not sure that the physician is the best person to have the conversation. You know, it's a question. Who is the best member of the care team to have this conversation? And maybe the best conversation is a conversation that happens. I also agree with your point about transparency. It's really hard. I don't know, given the complexity of our insurance system and all of the different components of care, I don't know that we can ever expect a single individual to be able to provide that information to each patient. I do think, however, we can say is the cost of your treatment is likely to be similar to a cup of Starbucks, like, depending on what, how fancy you want to get, or it's about the price of a used car, or it's about 4 years at a private institution for your child to go to college. I think, yes, it's really hard to know exactly how much any of this will be, but I do think we have a relative sense of how expensive some of the treatments are. So I agree with your points, but I also think that measurement, and I will say I'm a researcher, so I'm always interested in what we can measure.
Heather Spotts from Michigan State Breslin Cancer Center. Any thoughts about how many patients decline treatment due to the cost? Because I see that quite often. I'm an oncology social worker, so I will see that quite often in my work. And I just wondered, are there any stats out there on percentages or related to age group?
Yeah, that's a really great question. So some people refer to that as primary non-adherence. So like if you start a drug or a treatment and you don't complete it, that would be secondary non-adherence. Primary non-adherence might be where a treatment is recommended and you don't actually take it. So to my knowledge, the best estimates we have of things like that are for people who have a prescription called into a pharmacy, get to the pharmacy, and then don't pick it up. Depending on where you look, I've seen estimates as high as 40%. It's not clear, though, that these are just cross-sectional, so it's not clear to me that those patients didn't necessarily go back to their provider and say, this is really, I can't get this. Can you offer me something different? So I don't know what happens after that point, but it's increasingly, I think, a problem. And I also want to reiterate, prescription drugs is one component. There are multiple components to the high cost of cancer treatment.
Katie Beekman from IHA Hemonc. So in Michigan, one of our issues is oral chemotherapy drugs falling under prescription plan, and there's an oral parity bill trying to work its way through the state legislature. Are there areas in the country that are doing this well, that have less financial hardship for patients, and does that correlate with outcomes?
Oh, really good question. So despite the fact that I said the majority of the research has been done at the patient level, there's still so much we don't know very well. So I don't even know of anything that compares or that evaluates financial hardship by state. And the few studies that I am doing, I'm generally rolling up that information by state just because there's not enough people to look individually by state, but I think that would be really important to understand. And also, a lot of the work we are starting to do is looking at the long-term effects of financial hardship. So I think better understanding of the effects on outcomes is really important. So thank you.
Robbie Haney here, GYN oncologist at Henry Ford. I went to Iraq 2 years ago, held a conference in the surgeries and looked at the cancer care in the north of Iraq. And unfortunately, we have data locally from there that the financial toxicity is so huge that family members, because they can't get appropriate care within the country, they go either to Turkey, Iran, or Jordan and spend thousands of dollars. So what cost them $7,000 is literally a lifetime saving and more. And we know the cause of that is the government because they don't apply that. What is happening here? I mean, this is it's just like physician suicide. Everybody keeps the cap on it, but nobody talks about it at a governmental level. Is there are our policymakers working for us or for the 1% that Trump supports and yada yada? Sorry, I had to mention his name.
Yeah, I mean, okay, so what I will say in response to that question is that I agree that it's financial hardship is not happening just in the United States. It's happening in many other countries as well as many other developed countries. And I was in Toronto recently where there were, speaking on a similar topic. And there were a number of, I got a number of comments about how important it is, and patients and families are making changes to their lives, not because of a cancer diagnosis. So it is definitely an issue everywhere. In terms of what policymakers are doing, heterogeneous group, I think that some are not fully aware of the long-term implications of some of this, what seem to be minor changes in health insurance coverage that can have drastic effects on cancer patients and their families and patients broadly. I think cancer is such an important topic because the costs are so high, and also because families are so it's a disease where people will go to extreme measures to make sure they get care they perceive that they need. But I mean, this is not just a problem with cancer; it's a problem with all chronic disease. So in answer to your question about policymakers, I think that many efforts that people have made to make their views known to their elected representatives in multiple organizations have been very effective. And so that is probably as political as I'm going to go. But I think making sure that you're well educated and you can inform your representatives about your interests is important for the future.
Thank you.
Deanna Ball, I'm a cancer survivor. And I want to comment on the oral parity law in Michigan. We are one of 7 states in the United States that does not have oral parity, meaning that it would be covered as a copay with their insurance, just like it. Rather, it's a deductible. I have friends who have died because they could not pay $10,000, $12,000 out of pocket per month. I'm talking about per month cost here. It's criminal. And the new targeted therapies, many of the targeted therapies, we've had people sit on the committee of oral parity that indicate that those are superior treatments compared to IV chemotherapy. So it took them exactly 3 minutes to shoot down and send back to another insurance committee our bill was just reviewed a couple of weeks ago here in Lansing. So back to the drawing board, one more year that we do not have oral parity in Michigan. And it's just barbaric. There have been studies done that show the costs were contained comparatively for the changes that were made when it became treated the same as it would if you were in an infusion center having IV therapy. It's something, obviously, the group, we're very active, Michigan Ovarian Cancer Alliance, we're very active in pursuing and watching this bill and supporting it. So I just wanted to let you know where we stand with this effort. Thank you.
Thank you for that comment. And I will also say that my understanding of some of the oral parity laws is that they are restricted only to patients with certain types of health insurance. So to the extent that you are active in exploring this in the future, making sure that those are comprehensive across multiple types of insurance will be very important.
Healthcare insurance and the costs and the whole program is very complex, and I'm by no means an expert. I just want to say, though, however, I'm Canadian, and I live here now, and I've lived here for over 22 years. Healthcare here, to me, is still much better than what I've experienced and seen in Canada. My father, personally, my father was diagnosed with cancer, and he was on a wait list for radiation. So I just caution that this is very complex, but it doesn't always mean that other countries provide better care or have better access. In Canada, my mother's in a nursing home, and she can have services if she pays for it. So people always say that there are different programs out there that people have access to, and that's not necessarily the case. So again, this is very complex, but I just wanted to give my perspective in terms of, I just wanted to give my perspective on that.
Thank you, thank you. I will just add to that in this country, many people are concerned about rationing access to care. Like that tends to be, the word rationing does tend to come up whenever we talk about any sort of healthcare reform. But we currently do ration in this country based on ability to pay. And so that is, as the cost of cancer care is increasing, I think we will see greater and greater effects of, it's not, it's indirect, this rationing of access to care based on ability to pay, but I think as costs continue to increase, we will see more of it.
I'm sorry. Another question. Have you, in your research, since you are a researcher, have you looked at where, have you seen in certain health plans or certain states, counties, wherever, where this onion works, where most of this onion works together? Like you might not have the national, but where it works best, where there's like best practice, and how maybe there's a certain area where they have less financial hardship because they're working on this as a team.
That's a really great question. And I'm going to take that as a plug for better data to actually measure hardship geographically. Currently, we really don't have, in relation to cancer, we don't really have it. We do know that there are a number of cancers with higher incidence rates and higher mortality rates in states that have lower median income, who may have higher rates of uninsured in those states. So if you think, and you can look at this like maps. If you look at like Mississippi, Louisiana, some of the southern states do tend to have really high rates of cancers where there are, effective prevention, effective screening, and effective treatment. Can't say it's directly because of financial hardship, but we do have pretty big disparities in cancer outcomes across this country.
We probably have time for about 3 more questions.
Isabel Lay from, I'm a medical oncologist in Midland, Michigan. So I finished my training recently in hematology oncology, and I feel that in general, physicians are not trained to know how much the care that we're providing is going to cost the patient, and also costing the population as a whole. For an example, we talk about, as an oncologist, we look at numbers like progression-free survival, overall survival, but we don't know how much that overall survival is going to cost in terms of dollars. And I think that's something that we, in general, all of us needs to be educated on. I was trained very conservatively, which is kind of different compared to my young colleagues. I was trained with a breast oncologist who would put up the prices for the chemotherapy for metastatic breast cancer and tell me how much these things are going to cost my patients. And I'm more aware of not using things like Abraxane when it's not better than Taxol, for an example. And it's also eye-opening to know how much the PET scan is going to cost my patient, how much is the CBC is going to cost my patient. So recently I went to see a specialist at University of Michigan, and I got my bill for just a CBC, a CMP, a TSH, a folic acid, and a B12, very ordinary test, was about $700. So as medical oncologists and hematologists, we ordered all these fancy testing, the next-gen sequencing for leukemia, the factor V Leiden, antithrombin, blah, 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 very expensive testing, which we don't know what is the cost for the patient at the end of the day. And on top of that, and I really appreciate the Choosing Wisely campaign because it tells me the things not to order. And also on top of that, with the measures that we have to prevent some of our colleagues from doing those unnecessary testing as well. I see my colleagues ordering PET scan, CT scan to surveillance patients with treatment with curative intent. And honestly, I frown upon that. I just don't know how to bring it up. So maybe this would help.
So I'm going to ask you a question, actually. So based on your training where there was greater exposure, are there things based on that you would suggest would be useful for practice?
So seeing my bill was eye-opening, honestly. I have another colleague who is around my age who told me that one time he was told by one of his attendings to order a testosterone level, and the patient brought him the bill, and he was shocked how much the bill was. So I think seeing the cost of care to some of us is helpful, because the patients are not going to come in and tell us, oh, you ordered that Neulasta for me, it's very expensive. I had to pay 20% of $6,000 is $1,200 on that Neulasta shot for the 4 cycles of dose dense AC, that's times 4 is $4,800. In general, we want to give our patients the best care. But in the back of our mind, we're not remembering that there is a bill to pay. And when that patient dies, the family is going to carry that cost. So I'm in general very cost conscious as a person. So those things matter to me. So when I'm talking about, so sometimes I have a more senior colleague who I remind him that, hey, this patient is going to die regardless. You can give R-CHOP or whatever. I ask him the question, do you think this R-CHOP is going to save this patient in the hospital? And he said, no, I think the patient is going to die regardless. Then I said, then you owe the patient that. Tell the patient that I can do this, but I think you're going to die regardless of what I do, and the patient can choose not to get that treatment. You owe the patient that, because that is going to cost the patient at the end. And if I was the patient, I would like to know that.
I agree with you. I agree. Yeah. Yeah, and I didn't focus on end-of-life care as much today, but I think the discussion of cost of care is especially important at the end of life. So thank you for bringing that up.
This is Dan Sherman, Financial Navigator at the Lax Cancer Center. Can I make 2 comments? First of all, in response to your statements here, oncologists should be concerned about the toxicity that patients are experiencing, right? So you're concerned about cardiac issues, you're concerned about nausea, and it's time that oncologists are concerned about financial toxicity, which you are doing. It's just, if oncologists can start understanding this, and I agree with you, it's not necessarily, the oncologist shouldn't be an expert in knowing everybody's out-of-pocket responsibilities. I mean, that's impossible. But having appropriate staff in place to be able to do that is essential. The second comment here is there's a constant theme going on here. I don't know if you guys picked up on it, but it's the statement has been said over and over again, this is complex, right? This work is complex. And if you look at the data of who is doing this work, who is performing as a financial advocate, financial counselor, the data shows that it's high school graduate people, right? And so is it fair to put individuals in that type of a position to deal in extremely complex scenarios? Is that fair for that employee? Is it fair for the patient? Come this afternoon, we'll talk a little bit more about this in the breakout session.
Thank you. Thank you. I will say I just got the sign that we are almost out of time, but I am going to be here all day. And, you know, you can also contact me at my email that doesn't have my first initial, the secret first initial. You know, I'm glad to see this lively discussion. It's something I was really hoping for. So thank you so much. And it's been such a pleasure to be here to talk to you about an important topic. Thanks.